So I don't know about you, after that talk, I'm all fired up and ready to go to the next topic. So without further ado, I would like to introduce our next speaker for today, Dr. Chester Ho. So Dr. Chester Ho is a professor of physical medicine and rehabilitation and the inaugural spinal cord injury research endowed chair at the University of Alberta in Edmonton, Canada. He is also the facility medical director for the Glen Rose Rehabilitation Hospital in Edmonton, and he co-chairs the Provincial Pressure Injury Prevention Committee for Alberta Healthcare Science Services. Dr. Ho is a renowned clinician, researcher, administrator with a special interest in pressure injury prevention and how to integrate research into clinical practice. He has published over 140 peer-reviewed papers on top of rehabilitation journals and has received research funding from agencies including the Canadian Institute of Health Research, U.S. Department of Veterans Affairs, Brain Canada, and Craig H. Nielsen Foundation. He won the 2021 Champion of Change Award by the Canadian Spinal Cord Injury Rehabilitation and the Chinese Canadian Legend Award in 2023. And what a big round of applause does he really need right now, please.
Thank you and good morning. So I really liked how Dr. Chapman started her presentation with some personal story. So I also want to tell you something about myself. So what on earth is a physiatrist doing here? Talking about pressure injury. And so I wanted to share with you that, well, 20-something years ago, when I first got into residency in physical medicine rehab, I was exposed to people who were the most vulnerable, right? People with spinal cord injury and other disabilities. And I took care of quite a few pressure injuries. I thought, how on earth did they happen? How ridiculous it was that at this day and age that we still have so many pressure injuries. And that's what sparked my interest in pressure injury care. And guess what? 20-something years later, I'm still fighting the battle. And so here I am, and that's why I'm doing what I do. And I also want to say that specifically, I take care of people with spinal cord injury. And so we are continuing to see these pressure injuries on a daily basis. Okay, so there's no conflict of interest here for me to declare. And I have three objectives today. The first objective is to describe why pressure injuries are healthcare systems issues in Canada. And the second one is to discuss the strengths and gaps in the Canadian healthcare systems regarding pressure injury management. And then I want to finish by talking about some potential strategies to address healthcare systems issues for pressure injury management in Canada. So why are pressure injuries a healthcare systems issue in Canada? Well, when I first started as a clinician, I thought, well, you know, it's all about my care, my bedside, frontline care, right? But then as I actually progressed as a clinician and then as a leader in healthcare, I realized it's really not just that. Because if we don't have the right equipment, right? Even if we have all the technology, but not the funding or the staffing, etc., to actually utilize or access all of those good things, we still cannot do it. So let me just go through some of the statistics and data here to convince you that is a healthcare system issue. Actually, I have a suspicion that I'm just talking to the converted here anyway. And so basically, it was already mentioned by Caleb that in 2004, my goodness, 20 years ago, the paper by Woodbury and Houghton basically outlined that across Canada, the prevalence across all healthcare institutions was about 26%. My goodness, about 1 in 4 of our patients across all healthcare institutions got a pressure injury, right? That's quite high. And there hasn't been any national study since, so it's time for another one, I think. And then in Ontario, our very own Dr. Wu here basically looked at Ontario Health Administrative data between 2010 and 2013 and found that about 10% of all acute care patients had pressure injuries. 1 in 10, that's still very high. And then more recently, there's a global review and meta-analysis that show that over 1 in 10 hospitalized adults had a pressure injury. So again, they're quite consistent data, right? And in Alberta, we did a study a couple years ago. It's actually a bit different in that we did a manual audit. And we found that 1 in 6 patients had pressure injuries in our acute care setting. And guess what? It's actually using those data that we actually advocated in Alberta to make it a priority in our system. So I want to say that a lot of those studies use administrative health data, and they do tend to underestimate true prevalence. So even though 1 in 10 sounds high, but actually the true prevalence could be even higher if we use a manual audit method. So the bottom line is that the prevalence is really high. So apart from the fact that the prevalence is high, the costs are really high as well. And so when we talk about costs, right, we're talking about nursing time, medications, dressings, lab tests, patient and family costs. And oftentimes in healthcare, we talk about direct costs, things like, staffing time, medication, labs, etc. But we don't really think about the indirect costs, which are also really high as well, such as the cost of patient and family, time and distress and loss of productivity, etc. So I want to impress upon you that we do have to think about that. Now, in the US, we got some data there. Padula basically did a study a few years ago and found that for hospital-acquired pressure injuries, my goodness, the costs were over $26.8 billion in the US. And then in terms of the cost for hospitalization for severe pressure injury, it's over $129,000 US. That was studied reported back in 2010. So in today's healthcare costs, I'm sure it's much higher. Then how about some Canadian data? So Dr. Chan here in Ontario did a study for Canadian costing for pressure injuries in persons with spinal cord injury in home care. And basically, it's $7,000 to $9,000 per month. Now, that's over 10 years ago. Again, in today's dollars, I'm sure it's much higher. And in Canada, for older adults with hospital-acquired pressure injuries, the costs range from $44,000 just for stage 2 pressure injuries, and all the way up to $90,000 for stage 4 pressure injuries. And again, that's over 10 years ago, so I'm sure the costs are now much higher. And also want to emphasize that these are direct costs, not the indirect costs that we have not even measured, right? So we need to really think about that. But we know that it's not just about the cost of care, right? Let me ask you here, how many of you have hospital length of stay issues? So for pressure injuries, we know that from multiple studies, they're associated with increased hospital length of stay. And we also did a study recently in Alberta and confirmed the same findings. And basically, if you think about it, right, we have the cost of the treatment, but also the prolonged length of stay. So we are talking about not just the cost of treatment, but also patient flow issues. So that's a significant issue. And in terms of how we address this issue, it's not just the treatment, it's really mostly the prevention. Prevention is actually the best course for the reduction in the costing. In fact, in the Canadian Medical Association Journal from 10 years ago, there was a commentary that actually talked about how to improve the prevention of pressure injuries as a way to reduce healthcare expenditures. It's actually quite a nice commentary. So I want to show this here and encourage you to read it if you haven't done so already. And Dr. Chapman earlier mentioned about how we can align with some national agencies that talks about patient safety. So Healthcare Excellence Canada actually has pressure injury as one of the healthcare conditions that's listed under hospital harm. So I want you to look into that. And also in the US, the Agency for Healthcare Research and Quality also has a toolkit for prevention of pressure ulcers in hospital, just to show that they also felt that is a big issue as well in the US. And apart from all of those things that I've mentioned, of course, there's the elephant in the room, right? Medical legal risks. Because, well, though some of us think about some pressure injuries being unavoidable or unpreventable, but for the most part, I think that as experts, right, you agree that they're largely preventable. And so who have the liability? The hospitals, of course, and also even healthcare workers ourselves, we could be liable as well. So I want you to think about that. And there are already high-profile stories in the media on pressure injuries in Canada. And though we don't have published data that I could find, I'm sure that there are quite a few legal cases going on. And so I want you to really think about that. Even though we're not quite like the US yet, but I think that it could be heading that way. Okay, so now I think that I have painted a picture for you, right, as to why pressure injuries are a healthcare system issue. So I want to now switch gear a little bit and talk about what strengths we have in Canada about pressure injury management before I talk about some gaps. So what are our strengths? Well, we are pretty good at producing guidelines. And so the first one I want to bring to your attention is the Canadian Best Practice Guidelines for Pressure Injury from Wounds Canada. That was produced in 2018 and then last updated in 2021 and will be updated again quite soon. And so it's an excellent resource. And if you haven't seen it already, I encourage you to do so. And as a spinal cord injury doc, I have to say this, right? I have to show you the excellent guideline that was produced by our wonderful colleagues, Houghton and Campbell, and back in 2013 and supported by the Ontario Neurotrauma Foundation. Is a really comprehensive guideline for people with pressure injuries. And of course, I mean, Ontario, I must mention the excellent guidelines by RNAO. And this is actually in this 3rd edition right now, but in a few days' time, we'll have the 4th edition. So we are looking forward to seeing that being released. And it was also mentioned by Josh and Caleb already in the introduction that there is collaboration internationally for some guidelines. And so CPIAP, NSWAC, and Wounds Canada are all involved with the upcoming 2025 international guideline by the National Pressure Injury Advisory Panel that's based in the US, and the European Pressure Ulcer Advisory Panel, and the Pan-Pacific Pressure Injury Alliance. And so I think that I've mentioned about all of those wonderful guidelines, and now let's talk about accreditation. I think that we are fortunate that we have Accreditation Canada that has pressure injury prevention as a required organizational practice. I'm sure that all of you have been involved with this ROP, right? And so it's excellent. I'm even more excited to see the new ROPs coming out because it really has got some nice updates and also really clinically important. So I encourage you to look into that. And also across Canada, we have some really strong clinicians, researchers, administrators, all are interested in pressure injuries. So we have connections. I think that Canada, right, is such a large country, and yet we are quite closely together for certain issues. I think that pressure injury is one of them. So already CPIAP was formed, right, in 2021. That brings all of us together as an interprofessional body with representation across the whole country. And so I think that there's a really great opportunity for us to come together, as Dr. Chapman said, to be united in this really big fight against pressure injuries. Now, I also want to bring to your attention about data collection that we have. And the Canadian Institute for Health Information, or CIHI, collects national data for pressure injury. They also have published reports on pressure injury data in Canada. In fact, a couple of years ago, their report showed that the cases of pressure injuries rose from over 3,100 in 2017 to 18 to over 4,400 for the year ending March in 2022. So the cases are rising. Do we know the reasons why? I think that we all have our own theories and suspicion, right, as to what happened, especially over the pandemic. And I don't think that we know exactly why, because the data do not tell us why, but I think that we need to look into that. Now, having said that, CIHI is a really good infrastructure that we have. I want to come back to this when I talk about gaps in our system as well. And I really appreciate the fact that it was mentioned already before that patient and family voices are really important in pressure injury prevention and management. So I think that we are really fortunate that we already have increasing family and patient voices in pressure injury experiences in our healthcare system in Canada. And these voices provide an invaluable perspective to pressure injury prevention and management. I still remember when I was in a group discussion, a panel discussion in Alberta. So, right, we all agree that patient-centered care in pressure injury management is really important. Everybody nodded their head, everyone said yes. So I asked the question, tell me, what does it mean to you? What behavior do you need to demonstrate to be patient-centered for pressure injury management? Silence. Because when we agree on the principle, but what do we actually do about it? It's actually a different story, right? And so it was a really nice reminder for me that we still have to do a lot more, because while we actually really agree with this in principle, but how do we actually acknowledge, and not just acknowledge, but to carry out the practice that's patient-centered? I think we have a lot more work to do. And I just want to share this story here with a photo that came from Linda Moss. So thank you, Linda, for allowing me to use this photograph. And as you know, Linda has been involved with pressure injury, situation with her father before he passed away. And so she's been a really excellent voice of the patient and family as a result. So I want to thank her and her family for the work that they're doing. Okay, so now that I've talked about the strengths in Canada, let's go to the gaps in the country. Now, I think that it's no surprise to you that at this time, pressure injury is not really considered a priority for the most part in our healthcare system, right? And despite the high prevalence and costs, pressure injuries are somehow still not a priority. I think that it could be a priority in a healthcare setting, right? In an organization, in a hospital maybe, but as a system, in the jurisdiction across the country federally, it's not really quite a priority. I want to compare this to a silent pandemic, because here, right, we got data to show that 1 in 6 to 1 in 10 of our patients got a pressure injury in the hospital. What other conditions can you think of that really have that high prevalence across the hospital setting, right? And yet, how can we ignore this? So it's a silent condition, but it's also, obviously, a pandemic. That's why I want to call it a silent pandemic. And there's no clear accountability. I also want to ask you, right? How many times do you see somebody with a pressure injury that was hospital acquired? You know that something went wrong, but what happened to that? Was there like a root cause analysis? Was there a clear accountability on the part of the clinicians and in the system, right? Because maybe the clinicians tried everything, but then there was really no great support in the system for them to get the supplies or the staffing or the equipment, right, to support that. What happened to those pressure injury cases? Was there actually quality management that led to improvement afterwards? I've seen lots of cases that just went like, you know, let's sweep it under the carpet. And then it happened again. So maybe you've seen that, maybe you haven't, but I want to impress upon you that I think that accountability is a big one. Now, in the US, in 2008, my goodness, 16 years ago already, you know, before that, they had the same kind of situation, right? Accountability wasn't that great. But then in 2008, basically the Centers for Medicare and Medicaid Services announced that they may deny payment for treatments of hospital-acquired pressure injuries in healthcare systems. So suddenly, it's almost like overnight, the system changed. People started to pay attention to the documentation of pressure injury and also to the management of pressure injury. I'm not saying that they have eradicated pressure injuries in the US, but at the same time, the system started to pay attention. So I think that is a big lesson for us to learn from. Okay, now I want to move on to talk about the lack of an overall national strategy. So I think that we all agree that it's a universal issue, right, across the country. But there really is no national strategy for pressure injury across the country. And recently, CPIAP conducted a survey and found that there really was no jurisdictional strategy either, because when we asked the health ministries, right, across the country, really, there's no clear strategy. And oftentimes, it's up to the individual healthcare organizations. And I want you to think about health equity. If you have a region or a province or a jurisdiction with multiple organizations, they all have different standards or different, priorities. How fair is it to our patients and their families? I think health equity is something that we really have to think about. And also, when we have so many organizations that spend the time and effort to come up with something similar for pressure injury prevention and management, there's a huge duplication of effort. Do we have really excessive resources in the healthcare system? I don't think so. So why do we have to duplicate effort, right? So I think it's time to come together to try to join forces and really join the expertise together and to save time and effort to do a very concerted effort together. And along with that, we also don't have a clear data strategy. I've mentioned that CIHI collects national data, right? But at the same time, we don't really have a clear strategy for data, because what data should be collected, where, when, and how? And also, as frontline people, I'm sure there are lots of frontline workers here. I think that I hear this all the time, that there are questions about the quality of the data, right? When people question the quality of the data, they don't believe it, and then they don't use it, and that's a big problem. And I also want to mention that the national data is not really linked to any quality improvement work on pressure injury, right? Systematically speaking, it's really up to the jurisdictions. So I would say there's a bit of a disconnect there. So it's something for us to think about. And if we don't have clear data, then how do we measure our health quality and our outcomes, right? So we'll just be forever doing improvement without clear outcome measurements. So I think that's really critical. And then along with that, again, standardization of documentation. Now, I talked about a lot of studies using health and administrative health data, and guess what they base it on? They base it on documentation, right? When we don't have clear documentation, then we have a problem with our data. Wonder why our data are not that great. And so basically, we need to standardize that because right now we don't. And it really affects the quality of our work, the communication between providers, and also the accuracy of our administrative health data. And I talked about accountability already a little bit. And so what strategy do we really need to use? Should we be using a carrot or stick? I think it's sometimes, again, another elephant in the room, right? I think there's time for us to talk about that. Do we really need to use some positive incentive, or do we need to use the stick? But who has the big stick, you know? We don't know that. And then I also want to talk about our professional training. So despite the fact that pressure injuries are very prevalent and costly, my goodness, most undergraduate programs, right, don't really provide training. I know that at medical school, we don't really have that training, right? The only wound care training you guys would love was what? Wet to dry dressing, right? Everything was wet to dry dressing in medical school. And so basically, I want to bring to your attention that we need to have some better education. And we do have education, but at the more specialized level, right? And for instance, for NSWOG, there's an excellent training program, and also interprofessional programs like the U of T's International Professional Wound Care course. But for basic professional training, we don't really quite put an emphasis on something as prevalent as pressure injury. So something's not quite right. So now I've gone through all of those different, gaps and strengths. Let's talk about potential strategies to address healthcare systems issue for pressure injury management. So first of all, I think that we need to make it a priority of our healthcare system. And not that we haven't been doing that, in different jurisdictions, we have, but I think that collectively we need to do a better job. Now here I have listed some examples. So in Alberta, an effort that we have led was to actually look at the manual audit, right? And we found that, okay, 1 in 6 of our patients got pressure injuries in a hospital setting. And then we really went all the way up to the top of our healthcare system with this data. And then they accepted that this should be a healthcare priority in the province. That's how we did it, and we did. And in Nova Scotia, they also have done some great job. Now they have policies, including mandatory reporting for stage 3 and 4 pressure injuries to the health ministry. Congratulations to Nova Scotia for this really wonderful job. And in Manitoba, their ministry also has critical incident reporting guidelines for stage 3 and 4 pressure injuries as well. And then in some jurisdictions, they already have provincial skin and wound committees to try to look at this problem, right? Not just pressure injury, but wound care problems collectively across the province. So I think that's really great. So these are just some examples as to what we could be doing at a more system level. But I would love to see something done more nationally across the country. So along with that, I think that we need a national framework for pressure injury prevention and management. And we want to we want to avoid duplication of efforts, because when every jurisdiction does their own thing, it really wastes a lot of time. And I think that the CPIAP is in a very good, position to support that work, because there are already some great strategic priorities. And also there are representatives from across the country representing all of the jurisdictions. So I think that we are very nicely positioned to do that. And I mentioned data before, right? I'm a data guy, so I really want to mention this here. I think that there should be a national data strategy for pressure injuries. In fact, I'm just giving you a little preview here as to something that we are working on in Alberta. We are talking about a data strategy in the province. So we want to talk about strategy for data acquisition, data reporting, data analysis, and data utilization. So for acquisition, right, at what level? Is it at the unit level or hospital level or regional level or what? We need to really understand that. And what methodology do we want to acquire the data, right? And how do we ensure data quality along the way? And for reporting, do we really want to have mandatory reporting, just like Nova Scotia did? And guess what? By the way, that Nova Scotia, after they have done mandatory reporting, they actually showed improvement in their prevalence. Just food for thought. And then for data analysis, what methods do we want to use to analyze our data? And how often do we analyze that? And then lastly, for utilization, once we've done the analysis, so what? We need to utilize the data, right? We need to have a strategy for that. Okay, and then I also want to emphasize that we want to have some pressure injury education at all levels for clear reasons that I mentioned already. And I want to give kudos to the team in Ontario for having the ECHO project platform for skin and wound, because I think that's an excellent platform for interprofessional case-based education. So I would love to see Project ECHO for skin and wound across the country. So wouldn't that be wonderful? And back to accountability, carrot or stick. So what's the best approach? So, do we want to penalize facilities or organizations for having high prevalence of pressure injuries? Or do we want to say that, my goodness, they have high prevalence, so let's pump in some resources to help them address the problem? And also, Dr. Chapman already mentioned, right? How can we actually have some recognition for people who did well? So, for instance, the magnet status, right, for some facilities. And do we want to promote something like that as a positive reinforcement for people who do a good job for pressure injury prevention? I don't think that we've had some really good national discussion on these really important issues. Again, I feel like sometimes this is the elephant in the room, right? How do we use a stick or carrot approach? But I think that, as with most things, the truth is probably somewhere in the middle, using both approaches. So, just to summarize, I want to impress upon you that pressure injuries are prevalent and costly, and I call that a silent pandemic in our system. They're largely preventable, but system issues can pose barriers to effective management by our clinicians. And there's an opportunity for us to develop a national framework for pressure injury strategy. And when effective, or if effective, the strategy will improve the quality of life of patients and families, reduce hospital length of stay and overall costs. And I think that the CPIAP is in a very good position to support these initiatives. So I just want to acknowledge the different organizations and committees in Alberta that support my work. And thank you so much for attention.
Thank you so much, Chester. So now we're going to open up the floor to questions. If anybody has some questions for Dr. Ho.
I actually, was hoping to hear more about spinal cord injury and, stroke, those patients. I am the clinical educator for the wheelchair company. And, maybe we need to start addressing the gaps. We have a huge gap in education. So I'm very happy that you're talking to this group, one of the confidence center here. What I found in my role, I'm probably the only lost in the confidence nurse working for the wheelchair company, and I'm doing that. I educate interdisciplinary, and I work closely with OTs, PTs, and I am on a consultative basis with a lot of clients with events, very complex, building, non-building, people, flap surgeries, and all those that we sometimes hear that people love. So what I also know is in my role that we don't have any curriculum for nurses that would educate on the wheelchair scene. We don't have it even in specialty programs. We don't have it in regular bachelor programs. What I do know through my international work is that in some countries, knowing about the wheelchair seating, the principles of positioning, principles of all the materials used and how they interact with human beings. This is part of the regular curriculum in other countries on a bachelor level. In Canada, unfortunately, we don't have that. I'm also involved internationally on the ISO committee, International Standards Organization, and I'm leading right now the speaking assessment standard. And you would be surprised that even in the OT and PT fields, where it is considered that OT and PT, they are really prescribers of wheelchair seating, they also don't really have very thorough education on wheelchair seating, and seating assessment is not very standardized in our healthcare institutions. So I guess this is a little speech of advocacy. I am asking and begging everybody to maybe open up the mind and advocate for integration of this education into our curriculum, or maybe continuing education. So I'm not the sole fighter in this room. Thank you so much for the presentation. It wasn't a question, but I really am happy to hear from you. Working finally for the injury progress.
Yeah, thanks for your comments. I just want to also respond to that a little bit. I think that your point about education for all disciplines is a really important one. I also didn't quite mention before, right? I think that when I talk to my colleagues, it's oftentimes nursing colleagues, allied health colleagues, etc., that really respond, to the call for action for pressure injuries. But physicians are a group that we need to also target, because I think that physicians oftentimes don't have the awareness or the education on pressure injury prevention and management. So I want to put that out there, but I absolutely agree with you that education is important. But I also want to point out that, while the content expertise is important, but I think that at the strategic and policy level, it's also very important for us to support people to have that education, because I think that sometimes what I'm hearing from different jurisdictions is that people recognize, right, from their content expertise that they need to have more education, but they may not have the system support to actually design the education program or to deliver the program. And staff may not have time to may not be given the time to attend such education program. So I think that we need to think about it at the content expertise level, but also at the policy and strategic level, so that while we have the content expertise, but then it's also being supported for that to be delivered as well.
Thank you, Chester. Any other questions?
Thank you. It's Irving Mayor, again from Woods, Canada, and really, that was a great presentation. You really covered all the bases. I did want to draw attention to something that has happened in Ontario and Nova Scotia, which does reflect some of your comments. We've developed with government funding in both the provinces what's called the Wound Care Champion Program. It's not at the expert level. It is moving to looking at what competencies do all professions, so it's interprofessional, need in order to be sound wound care practitioners. The other piece with that program, and it's apropos to what you just said, is a component on knowledge to action or change management, which arms the graduates with some expertise on how might you approach your organization to have those policies in place. So that program has had extensive success in long-term care in Nova Scotia and really in home and community care in Ontario. And we're certainly working to expand it across sectors and across the country. And add a component, just as you said, that really is for organizational needs, the CQI needs. So they, in fact, can set up that structure so that the graduates don't come back and hit their head against a brick wall, nothing's changed. So you're absolutely right. And we're already moving there. I hear you. We need to gather, you know, it needs to be a snowball across the country where we do this. So thank you for the inspiration.
Thank you. That's great.
We have time for one more question. If anybody else has a dire question in the room. Oh, back corner, Josh.
I wanted to ask a question related to, you were talking about the focus on patient flow. And I was thinking about the challenges between patient flow and sometimes how that affects the development of new pressure injuries, whether it's waiting, a patient waiting in ER, on the right surface, not having the resources to turn appropriately. And down the line, a patient waiting to get into rehab. Certainly in Ontario, we're seeing a lot more that patients are being repatriated back to the community hospital, where again, there may not be the expertise and resources to support them. And then again, that next piece of it, waiting for rehab, getting into long-term care, getting home. I wondered your thoughts on where there exists some of those guidelines and position statements around thinking of pressure injuries across the continuum and that kind of tension with patient flow. Because I think that's something certainly I've seen has been a lot more magnified in the last few years, particularly with smaller populations.
Thank you for the question. So just to summarize for our clinicians and advisors online, the question was to Chester about how patient flow and those transitions of care make caring for and preventing pressure injuries possible.
Yeah, thanks for that really important question, because you know, when I talked about patient flow, I was really just talking about one small aspect of a huge problem there. So thank you, Heather, for that. And so what I mentioned before, right, was that when you have people developing pressure injury, it actually prolongs the length of stay, and so it creates a backlog effect, right, to affect patient flow. But on the other hand, when we think about patient flow across the system, my goodness, there's a much bigger problem that we have to think about, because in our healthcare system now, I think that we have such a high number of patients in emerge, waiting to be seen. The time spent in emerge is much prolonged, waiting for a bed for the inpatient unit, right? While they're in emerge, they could be on a support surface that's not appropriate, they're not being looked at, they're not being turned, they're not being really pay attention to, right, for their skin integrity. So that's one issue. And then once they're on the unit, you know that, as you mentioned, there are lots of transition points. We are somehow creating many more transition points for our patients in the system. When you have more transition points, again, it creates a higher risk for pressure injury development. So I'm not aware of any clear data to show us or to demonstrate that that's actually causing more pressure injury. But I think that we all know intuitively that that's a problem. But I think that would be a really important and wonderful project to look at, to see how the current system with patient flow issues is actually creating more pressure injuries, and how we need to prevent that, by addressing the specific risks for the different factors in that patient flow issue. So thank you for that.
Thank you, Chester. I also, just on that subject too, want to comment on the challenges with downstream admitting criteria. We all know as clinicians that you can have a patient with a stage 4 pressure injury, but it has healed to the smallest little wound that's easy to treat or to manage. But a downstream facility could look at that number, stage 4, and say, we can't accept this. So kind of understanding that we can't backstage to admit a patient. We need to keep the staging as it is, as per best practices, but understanding that it's the care that you provide to those patients and for those wounds that should be dictating admission criteria and not the label that we put on it. But thank you so much, Chester, and thank you for your questions, everyone. All right, we're now moving into a break. So please feel free to engage with the exhibitors around the room. We'll be reconvening at 11 a.m. Thank you, everybody.
And in terms of parents, I come to my work, you guys for paying attention.
It's almost great.